So, can you take us to the addicts and family therapy program and your work again with Duke Stanton? You already introduced it, but could you talk a little bit more about that?
Basically, they asked me, was I interested in working with heroin? And I was like, that's not on my life list. It was not something was particularly interested in. But he was coming from Vietnam, and uh, some of his experiences with folks who were addicted in Vietnam. So he eventually talked me into it. But originally, that wasn't on my list of personal priorities. But I did say, and this was a little cynical but true, that if we succeeded, the world would take note and we would be famous. But the other piece that was serendipitous was I really, really wanted to work with Hayley, and so did Duke. So he wouldn't work with us unless we were going to get people off of, not just off of heroin, but also off of methadone. And that was against the prevailing model at the time. I think I may have mentioned, but I was publicly accused of malpractice by a doctor in Brooklyn because of taking people off of methadone. And he basically said, that's the only thing that works. How can you justify having somebody be drug-free? And basically gave him Haley's rationale, which was as long as you're on something like methadone, you're still an addict. In terms of family dynamics, and this was Haley's too, that having somebody on methadone was really very, very little different from having somebody on heroin. So the family didn't have to change particularly with somebody on methadone, whereas getting the family drug-free was a whole different deal. They predictably went into crisis when the person was not on methadone any longer. Working with 2 or 3 cases like that was manageable. Working with an entire caseload, not so much, probably. So
some of your therapists were Paul Riley, Barbara Bryant, and Peter Urquhart. Mm-hmm. I know Barbara, and I knew Pete. I didn't know Paul. He died before I got to the clinic. Mm-hmm. But those are very important people, I think, in the history of family therapy because they were folks from the community. They weren't therapists that went the traditional route like you and I.
Right.
That they were part of Minuchin's commitment to the community and really bringing community-based therapists to the fore. He actually had to go to the state capitol and get some congressional changes to allow these folks to get reimbursed for their services because they weren't licensed like you and I.
Right.
Can you talk a little bit about Paul, Barbara, Peter, and your work with them? Because I just think it's something that deserves us to shine a light on.
These were people who were already important part of the community, probably already change agents, but at least people who are very much involved in the fabric of the community. Precious little training as therapists. So it wasn't like they came with the kind of graduate school pedigree by any means. But they were natural helpers, and they were people who basically, knew how to connect with people and knew how to set goals and understand what was getting in the way and stuff like that. So they were really, really, really fun to work with. And because of my position as the chief psychologist, I was also working with people who were coming for a psychology internship from all over the country. But those were people who basically had very orthodox academic training. They quickly realized that somebody like Paul Riley or Pete had skills and a background that they hadn't been taught. The students that we attracted were pretty humble and realized that somebody like Paul Riley, who was really, really difficult to supervise, brought something to the table that they were not getting in graduate school by any means.
One of the things I'm discovering in this interview is you and I have something very in common. Came to the Philadelphia Child Guidance Clinic as a pre-doc intern in psychology. So I don't know if you were the first director of the psychology internship program.
Yeah, I was.
So I need to put you on my professional genogram.
Okay.
And it changed my life. And I knew it would. Can you talk more just about the importance of training, but also some of the unique aspects of training that the clinic offered? You already touched on it some, about the extensive use of video recordings. David Abelson was the director of training when I was there, and we'd had four interns in our group. And David would say, "Oh, who has a videotape to present to the group today?" And my colleagues would go, "I don't." And then he'd look at me and go, "Steve?" I said, "David, I'll go get my tape." So I was always presenting and the thing is, it was so useful.
Oh, yeah.
And then also, I worked with a number of folks at the clinic that were very committed to live supervision. And I still hear that buzz, like in room 740, room 740 in the clinic, that, and it was like one buzz for this person, two buzzes for that person. Steve was always two buzzes. I hear that in my ear all the time going, and I hear voices that really continue to guide me to this day. It's just wonderful, wonderful, wonderful. Could you talk a little bit more about that? Because the center tries to continue to advance that, but there's still a lot of organizations out there that go, "Oh my God, we can't video record. Oh my God, we don't have time to do live supervision." Can you talk more about those sort of training experiences?
One of the things that's upset me some is that I don't see the tradition of live supervision going on to the extent that I think it should. It was hard to get agencies to allow videotaping, or allow live supervision, or sitting in on sessions. I think people paid lip service to the idea, but really didn't want it to apply to them. The other piece that was not trivial, I think, is that at the clinic, we had people coming from all over the world to train, and we had full-time interns and so forth. But the staff didn't necessarily get a whole lot of support and clinical feedback and stuff. And the staff were not necessarily doing live supervision and stuff like that. So, and Harry was good about that. I mean, Harry, as the director of the clinic, really did press for staff to get some of the goodies that people were coming from all over the world to get. But he wanted to make sure that people who are on staff also got the goodies.
Tom, if you enter in Google Scholar now, like live supervision of psychotherapy, live supervision of family therapy, you know what's going to be the top hit? It's going to be Braulio Montalvo's article from way back when on guidelines for orchestrating live supervision. He's still cited because there's not much out there, man.
No, there's not. That's really true. Yeah.
I noticed in your professional critical event timeline, I think you might have left the clinic in the mid 70s, and you went to Harlem Valley Psychiatric Center. Mm-hmm. Can you talk a little bit about your decision to leave the clinic and go there, and what that was like?
I had made a promise to my wife that after I finished my postdoc, that we would move back essentially Westchester County, or slightly across the state line into Connecticut, to be close to her family. She was an only child. And the problem was there was no child guidance clinic in Westchester County that we could move to. There was nothing at all similar. So when I tried to move back to Connecticut, eventually I decided, well, I'm it's kind of ridiculous because it seems like it's a very ancient sort of institution, but I should at least go and check it out. And it just happened that they had a new director of clinical services who was in his 30s and was very, very interested in developing community services, which were very underdeveloped on the state level. No state services really, outpatient. And we had a psychiatrist director who wanted to become famous. I think wanted to become the head of mental health, but there was no money for it. The only way that there was money was to empty the hospital. And if we could get people out of the hospital and continue to be able to use the money, then we had money for outpatient services. And so I got hired to develop services in Putnam County, which is just north of Westchester County. And there was nothing there. Putnam County didn't particularly want services, and the county people especially didn't want the state to come in. They said basically, you have to wait in line for license plates for your car and stuff. You can wait in line for therapy. And we also provided 24-hour crisis services because whenever somebody would be hospitalized, they'd be hospitalized at Harlem Valley. So we wanted to keep people from unnecessary hospitalization. And so we developed a 24-hour crisis team. We hired a bunch of psychiatrists because they were employed in Connecticut, and they could be part-timers across the line in New York and make some extra money. So we were well supplied with psychiatrists, and we had a 24-hour crisis team. So we had fabulous services, truthfully.
But see, Tom, what I really appreciate about that story is that you wrap your mind around the idea that the clinic wasn't just brick and mortar. It's really a way of thinking.
Right.
And that you can take it anywhere you go. Yeah. And to me, that's just real pivotal. A lot of times I've heard, well, you're in Philadelphia, you can do that in Philadelphia, but you can't do that here. Au contraire.
My condition was, because there seemed to be a lot of resistance within psychiatrists of short-term therapy and family therapy and stuff. So I said, I didn't need to boss psychiatrists around. My only condition is I want to control the intakes. So I want my staff to do all the intakes. So that turned out to be crucial. And the chief psychiatrist, who was not particularly a family therapist at first, was part of the intake process. But he was also a quick learner, and he really quickly learned that it wasn't just a matter of analyzing the individual, but that it was really important to assess the family or the marriage partner or whatever. So it was fascinating. It's a lot of fun.
It's fascinating. Again, you took Jay Hayley with you, where the assessment is the intervention in many ways.
Yeah.
It's fascinating, isn't it?
Yeah, totally. Yeah.
It's so much fun.
Great fun. Yeah. And so the chief psychiatrist learned fairly quickly that if he was involved in presenting a case to the intake group, that he was going to have to understand the context and not just talk about the individual.
Harry would be pleased to hear that too.
Indeed. Yeah.
I'd like to express my appreciation for everybody attending today's blog. Dr. Todd is such an interesting innovator and contributor to the growth and development of family therapy. It was so fun spending some time with him today. But what I also appreciate is how each and every one of you are figuring out ways to be a part of this process too by joining us. And with that, our appreciation. Thank you.